In this presentation, an intra-articular fracture of the distal tibia will be reduced and stabilized using the large external fixator in an ankle bridging frame with multi-pin clamps. The objectives of the exercise are to understand the clinical indications for the application of a large external fixator, the positioning and correct insertion of the shunt screws, and the construction of the ankle bridging frame using multi-pin clamps. The most common clinical indications for the application of the ankle bridging frame include intra-articular fractures of the distal tibia with severe soft tissue damage, either open or closed, including complex fractures of the distal tibia or pilon fractures. For damage control surgery in polytrauma patients, and acute and chronic infections in both fractures and non-unions about the ankle. The instruments needed are the compact air drive, the quick coupling, the drive adapters with quick coupling for 4 mm and for 5 mm shunt screws, the 3.5 mm drill bit, 2 5 mm diameter self-drilling shunt screws, 175 mm long with a thread length of 60 mm, which will be inserted into the tibia. 2 4 mm diameter self-drilling shunt screws, 125 mm long with a thread length of 40 mm, which may be inserted into the 1st and 5th metatarsals. And a Steinmann pin, 5 mm in diameter and 250 mm long, which will be inserted through the calcaneus. Also needed is the drill sleeve assembly. It includes both the standard and the 6-position drill guide handle, both the long and the short 6.0, 5.0 threaded drill guides, the long and the short 5.0, 3.5 drill sleeves, and the long and the short 3.5 trocars. The universal chuck with T-handle may be used to advance the shunt screws. Needed for the construction of the ankle bridging frame are 1 large 6-position MR-safe multi-pin clamp with optional rod attachment, 4 large MR-safe open adjustable clamps, and 2 11 mm diameter carbon fiber rods, in this case 300 and 350 mm long. Required to tighten the frame assembly are the 11 mm socket wrench and the 11 mm combination wrench. The zones through which the shunt screws can safely be inserted into the tibial shaft, the distal tibia, and the mid-foot are shown in this illustration. The bone model is secured in the clamp. Using the 6-position drill sleeve assembly, the long sleeve is placed directly onto the anteromedial aspect of the tibia. The first shunt screw should be positioned about 1 cm medial to the tibial crest in the mid-sagittal plane to ensure a bicortical placement. The trocar is removed, and since self-drilling, self-tapping shunt screws are used, the drill sleeve also is removed. A shunt screw is inserted into the adapter, and the power drive is used to advance this first self-drilling shunt screw through the outer drill sleeve. The drill sleeve is positioned so as to ensure purchase of the shunt screw in both the lateral and the medial cortices. In the clinical situation, irrigation is recommended while inserting the shunt screws. The image intensifier can be used to check the final position of the shunt screws. The tip of the self-drilling shunt screws must be anchored in the far cortex to ensure stable fixation. Penetration of the far cortex is not necessary. Once the shunt screw has been placed, it's released from the adapter, and the drill sleeve assembly is removed. The 6-position drill guide is repositioned so that the short sleeve passes over the shunt screw. The long sleeve is placed directly against the bone surface, and another shunt screw is introduced distal to the first one in the same manner. A centrally threaded Steinmann pin will now be inserted into the calcaneus. Once again, the drill sleeve assembly is inserted directly onto the bone surface, and the trocar is removed. The pin should be positioned in the posterior plantar aspect of the calcaneal tuberosity. Using the 3.5 mm drill bit, a pilot hole is drilled from medial to lateral. The drill guide is removed, and the Steinmann pin is inserted with the power drive. After the Steinmann pin has been correctly placed, it's released from the power drive, and the drill sleeve assembly is removed. The multi-pin clamp is passed over the shunt screws in the tibia, and is provisionally tightened with the socket wrench. The plastic cap is removed, and the optional rod attachment is connected. One large, MR-safe, open adjustable clamp is attached medially to the calcaneal Steinmann pin. Another clamp is attached laterally. An 11 mm carbon fiber rod, placed medially to connect the multi-pin clamp to the open adjustable clamp, is now snapped into place. Both the open adjustable clamp and the rod attachment are initially tightened by hand. The second carbon fiber rod, spanning the lateral aspect of the ankle, is snapped into place. The clamps are first tightened by hand. After the fracture has been reduced, the clamps are provisionally tightened with the socket wrench. After another clamp is attached to the medial carbon fiber rod, a 4 mm shunt screw is introduced into the first metatarsal, using the previously demonstrated technique. The shunt screw is inserted using the open adjustable clamp as a guide, and will assist in keeping the ankle from equinus. The shunt screw is released from the clamp, allowing the drill assembly to be removed. It is then snapped back into place, and the clamp is first secured by hand. The clamp is definitively tightened with the combination wrench. On the lateral aspect, a 4 mm shunt screw is introduced into the 5th metatarsal and connected using the same technique. The ankle bridging frame using a multi-pin clamp is now complete. The correct relationships of the elements can be seen in the different views. Another frame will now be constructed using a distal multi-pin clamp instead of the calcaneal Steinmann pin. The shunt screws in the tibia are positioned, following the previously demonstrated technique. Using the 1st and 5th positions, the 6th position drill guide assembly is placed directly against the bone at the calcaneal tuberosity and the neck of the talus. After removing the trocar and the drill sleeve, a shunt screw is inserted into the talar neck with the power drive. Using the same procedure, a shunt screw is inserted into the calcaneal tuberosity. With the second shunt screw in place, the 6th position drill guide assembly is removed. A multi-pin clamp is now passed over the shunt screws in the foot, positioned, and provisionally tightened with the socket wrench. After the second multi-pin clamp has been secured to the shunt screws in the tibia, a carbon fiber rod is snapped into place and initially tightened by hand. The distal fragment is manipulated to reduce the fracture by grasping the distal multi-pin clamp. Manual traction restores the length, alignment, and rotation of the limb. To secure the reduction, the nuts of the multi-pin clamps are provisionally tightened with the socket wrench. Definitive tightening is done with the combination wrench. This presentation has demonstrated the clinical indications, the positioning and correct insertion of the shunt screws, and the construction of the ankle bridging frame using multi-pin clamps.